I'll wait a few minutes. Yeah, let me go back to the.
But not too long. I know you've got a lot of slides, so.
Yeah, no, that's fine. And it's 70. Fab. I might get started now then, actually, because I don't want to overrun too much, if that's okay.
Go for it.
Fab.
See you later.
So thank you so much for everyone who has tuned in this evening. I'm really grateful for you taking your time out to come and listen to what I have to say. My name's Sophie. I'm a doctor based in Cornwall. And I'm going to talk to you today about medical on call. So if you've been asked to see a patient. So just a bit about me. That's a photo of me, because I know when people present online, you get a little box, and it's nice to have another photo. But I went to medical school in Manchester. I integrated in London, and then for the past 2 years, I've been based in Cornwall doing my foundation training, and I'm just about to finish F2. This is just a bit of an overview of what I've done the past 2 years and what I'm doing next year. So I started FY1 and respiratory, then had general surgery. I then did a bit of a weird job where I did 2 months of clinical radiology and 2 months of AMU. And then this year I've done community geriatrics, emergency medicine, and then diabetes and endocrine. And next year I'm doing a major trauma fellow based in Nottingham, so I'm moving. And actually I realised today that all my jobs but the radiology job had on-call or out-of-hours cover. So hopefully I've acquired some information which will be useful for you this evening. So I've split the talk into kind of an A to D, and that's just because I like to split things into parts in my head. I'm going to talk not really much about the airway, but focus more on if you're asked for someone with low saturations, high BP, low BP, major hemorrhage, and then hypo and hyperglycemia. I'm also going to talk a little bit about cardiac arrest. I'm aware that some of you will be going into trust where there's MET calls, so medical emergency teams. I've not actually worked in a hospital with MET calls, so I don't feel I can talk too much about it, but the principles of managing an unwell patient are the same, so hopefully should be helpful. The thing to know about on-calls, and I think it's important to realise, is that when you go from day to evening to night, which is kind of how the shifts are split up in most hospitals, there's a change in staffing. So during the day on a ward, you might have 3 to 4 doctors per ward, and then in an evening and night, we have kind of much less staffing. So in our hospital, as a F1 and an F2, overnight, I would cover about 180 patients. There would be another doctor that would cover the other half of the hospital. And then there would be a med reg that covered kind of both, like the entire hospital, but helped out with both of us if we needed any help or support at all. And that can seem quite daunting. But don't worry, everyone copes with it. You will cope with it, and there is support there if you need it. The mainstay to any on-call is having a good list. What I always do is I get an A4 piece of paper and then I fold it so it has 8 boxes on, and then I dedicate each box to a patient. It's really important to write every job you get down, or everything you want to do down as you get it. I think I cannot express this enough, because you sometimes will have a quick succession of bleeps, and by the time you've got the third bleep, you've forgotten what the first one said. So I always write everything down as I get it, even if it's very untidy scrawl and I have to rewrite it later. In my little box on the A4 piece of paper, key bits of information you want to have is where the patient is. What bed that number they're in is also quite useful, although you can look it up on our online system if you need. The name of the patient, and then the hospital number as well. And that just means you can kind of find them on the system if you need to. This might be something that you're aware of. If it's not, I would highly recommend being aware of it. But when you write your jobs list, I don't know when this started, but every doctor seems to do it. You write a little box next to it. And if you've done the job, or if you've ordered the investigation or sent the blood result, you half colour in the box. And if the job's completed, it's coloured in, and that just helps you keep track of everything that you're doing. I'm a big fan of a highlighter. To highlight, it's normally useful to highlight the name of the patient or the name of the ward. Particularly if you're covering multiple wards, it helps you keep track of where you're going, and it can kind of help you plan your route around the hospital. And documentation is obviously a really important part of an on-call shift. So if you're documenting in the notes, this is the structure on an on-call that I generally like to use. It doesn't have to be super detailed, and if it's something simple, then you don't have to write a whole review. And the only other thing I'd say is when you start, if you speak nicely to your ward clerk, they're often able to order you a stamp, which means you don't have to write out your GMC number every time you go and see a patient. Patient flow is something I really did not appreciate before I started working, and it really influences your work in the hospital. So ideally, what happens is patients come to an admitting area of the hospital. So they start in the emergency department. They might be seen in, so we have the same day medical assessment area and the same day surgical assessment area, which is where GP referrals can be sent into. After that, they should go to an admitting kind of inpatient unit, so the acute medical unit or the emergency surgical unit. And then from there, they should go to a medical surgical ward. If they're really unwell, they might go to intensive care, or they might go to a mixed ward, which is either could have medical and surgical patients. And finally, when they're discharged, they'll go to the community. So they might be followed up with the GP, seen in an outpatient clinic, go to a community hospital if they're not quite ready to be discharged fully, or go to a nursing and residential home. That's how it all should happen. With the NHS, how it currently is, that doesn't mean that's always the case. There's lots of things that affect patient flow, and the reason it's important for an on-call is it just helps you have an awareness of where patients might be coming to if you see them on the ward, or coming from if you see them on the ward. Hospital pressure, so ambulance wait times. Unfortunately, true, we have to board patients, so you sometimes have more patients on the ward than you should. Infection, so COVID can mean that bays are closed, and community resources, so community hospitals might be full and not have any space, and then packages of care might not be available, so people can't be discharged. There's lots of logistics with an on-call, and I kind of went over what I thought was useful, and I just want to talk a bit about news scores, handover, prioritization, bleep outcomes, skill set, and then a very small bit about prescribing. So in our hospital, and it might be different everywhere because places have a range of whether it's electronic notes or electronic observations, but we have an online system for all our observations. And the thing that's really useful to do at the start of an on-call is look at all the patients you're covering and see if anyone's using a high score. It just gives you an indication that they might cause you problems later down the line, or if it's significantly high, you might want to head and have a look at them at the start of the shift. Handovers come in lots of different ways. So it might be verbal, it might be written. If it's a verbal handover, it might be face-to-face, or it might be over a phone or a bleep. Written handovers come in the forms of kind of electronic systems. So we have some jobs which are put on our kind of online electronic system, which you have to check as well. So just make sure you're aware of how your jobs will be coming to you, because some places might have two. In terms of prioritization, I think one of the most important questions to think if you get asked to do something is, does this need to be done now? You need to remember that you're covering many more patients than you would be during the day, and it's not feasible for you to achieve everything. And so it is valid to ask, does this need to be done in the middle of the night, or can it wait for the morning? Once you get a bleep and you've been given your task, and you've decided you are going to do something about it, there's a number of different things you can do. And again, I've kind of tried to split this up to make it easier for you to think in those initial on-calls when you're getting used to working in that way. So you might not need to go and see the patient, and you might be able to provide advice over the phone, or you might be able to ask someone to do an action over the phone. Alternatively, you might feel that you need to go and review the patient, which might need to happen immediately or non-urgently. And I think that kind of having that in the back of your head is useful. Think about the skill set on the ward. If you're being asked to do something, it's often good to ask, is there anyone on the ward who can do this? Not being lazy. At the end of the day, you're covering much more than the nursing staff. And if there's someone that can do those bloods or that catheter, it means that you can then go and review someone else, and just spreads the work out more evenly when there's one of you, but lots of other people still working. Another thing that I think is useful to be aware of, which I definitely didn't kind of do very well at the start, is you might get asked a lot to do cannulas. And it's important to ask, what is the cannula for? If it's for a drug that's only due at 6 in the morning, you don't need to rush to do it, and someone else might be able to do it. If it's for fluids, Do they really need the fluids now? How much of the fluids have they had? It's just questions that can help you prioritise the task amongst all your other jobs. In terms of prescribing, we have electronic prescribing. Not all places do. I would err on the side of caution with prescribing remotely. If it's something simple, I normally put a stat dose, and I'm happy to do it remotely. But just make sure you always check renal function, past medical history, and the drug chart as well. When you're on calls, it will be patients that you don't necessarily know as well. So just be careful with prescribing when you're not on the ward and you can't see all their notes. Because for us, the notes are kind of paper, so you can't always see everything that's been going on recently if you're being asked to do it from far away. Chasing scans and results will become the bane or joy of your life as a junior doctor. And it's something that you'll frequently be handed over to as well, because the results the scan or investigation has been requested. It's been maybe sent off, but the result's not back yet. One thing that's important to think about is whether or not that result's going to come back when you're still on your shift. So if the bloods have been sent off, what time were they sent? Did they actually arrive at the lab? What sometimes happens is the reason that they've not come back is because they were never sent or didn't arrive in the first place. Also, be aware of people saying, oh, I've just sent some routine bloods, I don't think they'll show anything abnormal, because in my experience, it's definitely sometimes the routine bloods where you don't expect anything to be wrong that finds something abnormal that you need to action overnight. And for scans, it's worth questioning, is this scan going to be completed out of hours? Because if it's going to be done tomorrow, there's no point me chasing it overnight. If I'm asked to go and see a patient, what I normally go and do if I'm going onto the ward is go and have a quick look at them. That kind of initial eyeball normally gives you an indication of whether you need to start doing something straight away or assessing them straight away, or you have a bit of time to go and find some information. There's lots of different places you can find information if you've never seen before. The nursing team are really valuable. They have spent the whole shift, if not longer, with the patient. The HCAs are really good as well. They probably spend the most amount of time in the bay of the patient, so they can give you an indication if how that patient looks is how they always look, or if actually they've deteriorated quite suddenly. Looking at investigations is really good. So bloods, radiology, and then documentation and notes. So clerking, the post-date ward round, the most recent ward round, and any other documentation as well. And then drug charts, so medication, fluids, and nursing charts, so fluid balance, stool chart, and blood sugar. This is something that one of the consultants said to us when I was in my ALS this year. And I find it so useful because I definitely turned up to a lot of unwell patients when I was in F1 and kind of froze and didn't know what to do. But if the patient's alive, then it's an AT. But if it's deaf, then H's and T's. And by that, we mean if they are not responsive, then you need to go down the ALS algorithm of commencing CPR, and thinking about reversible causes of cardiac arrest. If not, and you've got an unwell person in front of you, go through that A to E and systematically work through the things that could be going wrong and treat them as you come across them. And that will really help you when you arrive, you've not met them before and you don't know what's going on. Again, I said I wouldn't really talk too much about airway. You won't be expected to manage an airway much as an F1. And if there was any situation where you were worried about the airway, I'd pretty quickly want to get someone there to help, either by putting out a MET or a crash call. So if we're thinking about hypoxia, again, go through your A to E approach. If you're worried that the patient's peri-arrest or arrest, it's more than acceptable to put out a MET call or a crash call. You'd much rather put out one too early than wait too long and put out one too late. It's more, when you start, it's more than acceptable to ask for help when you need it. Remember that different patients have different target saturations. So normal is 94 to 98, but the hypercapnic range is 88 to 92. One of the conundrums I've definitely had when I've seen patients is the target saturations haven't been documented. If that's the case, it's valuable to look in the notes. Sometimes it's been documented by a consultant or in the post-take ward round. If you look at their past medical history and they've got COPD and a smoking history, that might give you an indication as well, but it doesn't necessarily mean they're 88 to 92. And some patients will have had previous VBGs or ABGs, which can help you decide as well. But if you're unsure, it's always okay to ask for a senior opinion too, because it's important to aim for the right target range. If we are considering respiratory support, there's different levels of what can be provided. Any ranging from oxygen therapy, going up to high flow nasal cannula, non-invasive ventilation, intubation and ventilation, and then in specialist centres around the UK, you can have ECMO as well. ECMO can only be provided in certain centres, but it's also important to be aware that if someone is on NIV or if they're ventilated, they probably can't stay in the ward setting. So NIV is normally delivered on the respiratory ward or in intensive care, and ventilation is predominantly delivered in intensive care. So the respiratory support that a patient had determines where their care can be delivered. For oxygen therapy, this can be delivered in pretty much all the areas, the inpatient areas of the hospital. And there's a range of delivery methods, ranging from nasal cannula, a simple face mask, Venturi masks, and then a face mask with a reservoir, or a non-rebreathe, as most people know it. Little tip about the non-rebreathe, you need to make sure that the bag's inflated. So if you're putting on a patient, just place your finger over the valve, the bag will inflate, and then you can use it. That's really important that that's done. If any patient is on oxygen, or you're putting any patient on oxygen, it's really important to check the flow rate at the wall. So the little glass tube, there's a little nozzle and you turn it, and the ball determines the flow rate. And the reason for that is because different delivery methods require different flow rates, and they have an upper limit. So for example, a nasal cannula can only have a max flow rate of 4 litres per minute. A simple face mask can go up to 8, and a non-rebreathe mask goes from 10 to 15. If you need to go less than 10, it's probably better to go back to a simple face mask or a nasal cannula. Venturi masks are really good if you want to kind of get a very specific concentration of oxygen, and they're really useful for those hypercapnic patients where you want to get that target range right. The different colours indicate the flow rate and the percentage of oxygen that they're delivered. And that's kind of, as you can see on the slide there, that determines which one's which. If you can't remember them, don't worry, because it's actually on the little nozzle. So if you're confused, I normally ask the nursing staff to just bring all of them, and then you can work out which one the patient needs to get the right oxygen saturation. In terms of causes of hypoxia, I've kind of split it into oxygenation failure and then ventilatory failure. So oxygenation failure can be caused by a number of things. So PE, pneumothorax, pneumonia, pulmonary edema or a pleural effusion, exacerbation of asthma, COPD, bronchiectasis or fibrosis, lung cancer or anemia. And then ventilatory failure could again be caused by an exacerbation of an existing condition, drugs such as opiates or benzodiazepines, CNS pathology, and then thoracic wall problems, so pain, abdominal distension, obesity. One of the common causes of pain is rib fractures, which aren't managed properly, and then the patient struggles to breathe. What setting should the flow rate be on the wall for the Venturi? Is it yes? So on the Venturi, it will say the flow rate. So it will say like 4 litres per minute, and that's what it should be on the wall. And then it will say the percentage below it. So the percentage is what will be delivered. You don't need to adjust that. And then the flow rate is the number on there, so it'll be on there as well. And then lastly, neuromuscular disease as well can cause ventilatory problems. Red flag symptoms for hypoxia would be chest pain, hemoptysis, dizziness. Bit of an annoying symptom is in that it can have benign causes. Palpitations, breathlessness, throat swelling, and bleeding. So One of the things I've definitely been bleeped to about before, and is difficult to know what to do about out of hours, is high BP. What's really important to do is to look at the trend. So because our observations are all online, it's really useful in that you can look at what the past hours have been like, the past days and the past weeks. And that shows you, is this new? Is this kind of been sitting high since the patient was admitted? What sometimes happens is when the patient's admitted, they have a low blood pressure, they're already on antihypertensives, which get held, and then their blood pressure slowly creeps up during the admission because it's not restarted. What you want to be worried about out of hours is an accelerated or malignant hypertension. So that's a severe increase in blood pressure with signs of retinal hemorrhage or papilledema. I would only tend to start getting concerned about blood pressure out of hours if it's new, symptomatic, and the patient has blood pressure over 180 systolic. Aside from that, I don't tend to do that much out of hours. What you don't need to worry a lot about out of hours is long-term management of hypertension. There's lots of guidelines on NICE, and that can be followed during the day. But I wouldn't stress at 1 in the morning about sorting out someone's long-term hypertension unless there's an acute problem. Red flag symptoms to look out for would be headaches, fits, nausea and vomiting, visual disturbances, chest pain, or a neurological deficit. If any of these symptoms are present, I'd want to do a bit more digging about what's going on and what's causing the symptoms. At the other end of the spectrum, I think something I more probably frequently get called about is a low BP. And there's lots of different things that can cause this. So it might be that the patient's dehydrated because they're not eating very well, they're sweating, they've got diarrhea, vomiting, polyuria, or burns. Hemorrhage can be traumatic. On a medical ward, it's probably more likely to be gastrointestinal. Third space loss can be caused by ascites or acute pancreatitis. The patient might be septic. Drugs, so diuretics, beta blockers, calcium channel blockers, nitrates, ACE inhibitors, or opiates can cause hypotension. And it could be cardiogenic, so heart failure, acute coronary syndrome, cardiac tamponade, valve failure, or an arrhythmia. IV fluids we will give for 3 reasons: resuscitation, replacement, or maintenance. And if we're thinking about resuscitation, NICE has quite nicely summarised the reasons we might think about doing that. So a low systolic, less than 100, a heart rate greater than 90, delayed capillary refill time, if the patient's cold, if their respirate's up, if their new score is up, or if you raise their legs up and it improves their blood pressure, that suggests that the patient will be responsive to fluids. Again, there's quite a nice summary on NICE about IV fluid therapy for inpatients. It's not the sort of thing that I think you would need to look at out of hours, but if you just want to get your head a little bit about fluid resuscitation and maintenance, then that's it's a useful thing to maybe just have a look at some point. IV fluid prescribing considerations, because it's something that you'll get asked to do a lot, and something I don't think I got my head around before I started working, but feel a bit more, definitely more confident doing now. So make sure you've had a look at their past medical history. So if the patient's got heart failure, you definitely be more cautious giving them fluids. If they've got an AKI, you do sometimes get patients with heart failure and an AKI, which is challenging. And that's where I definitely get some senior advice, because it's a balance between making sure that they are hydrated, but not overloading them. And then patients with CKD, just highlight the value of looking at the trend, because you might look at a blood result and panic because their EGFR is 10. But if that's their baseline, it's less concerning than someone's EGFR that's just plummeted from a normal level. Make sure you look at what fluid they've had before, so you don't give them loads of fluid. It's important to know how much they had over the last 24 to 48 hours. If the patient's eating and drinking, they might just be able to increase their oral intake rather than requiring more IV fluids. But if they're nil by mouth, they'll need some maintenance fluids as well. And it's always valuable looking at electrolytes to make sure you know what that is before prescribing anything else, because they might need IV electrolyte replacements. And checking the HB can check whether you need to give them blood rather than fluids. And if they're on a fluid restriction, you obviously don't want to give them fluids IV. Sorry, my slides are just taking a moment to load. Fab, there we go. So if you feel that someone's suffering a major hemorrhage, then it might be that the major hemorrhage, at that point, the major hemorrhage protocol would be activated. So this is a 222 bleep activation, which starts the major hemorrhage protocol in blood bank. It can be activated from any clinical area, and the location must be stated when calling switchboard. And the aim is to allow a rapid and appropriate response to major hemorrhage in the hospital. There's 4 main causes of major hemorrhage. So trauma, surgery, obstetric, and medical. As I said before, the most common cause, I would say, of a medical major hemorrhage would be a GI bleed. These patients can be really unwell, but there are situations where it's anticoagulant related as well. There's these really nice definitions about major hemorrhage, which talk about blood volume and total blood volume loss, or the amount of blood loss per minute. In reality, and in clinical settings, I think it's more useful to have a practical clinical definition, which states any active bleeding which leads to a systolic less than 90 or a heart rate more than 110 in adults. Obviously, children are different because they have different physiological parameters. Essentially, the steps are recognition, activation of the major hemorrhage protocol, and then samples being taken and ensure delivery to the lab, which normally involves avoiding using the pods and walking them there, either someone else or yourself. Different hospitals have different methods of using a group and save, taking a group and save. So when I was in Manchester, the hospitals that I was in, some of them required you to take 2 samples. In Truro, we have a method where we have like different machines that scan barcodes on you and then the patient and then the patient again. It's essentially just to make sure that they're labelled properly and that there's no mistake with mislabeling, because it's obviously important if you're giving someone blood that the blood has been matched properly. But it's important, I would say, one of the things that's worth finding out, and you should be told in your induction, is how that works in the trust that you'll be working in. Essentially, the major hemorrhage protocol means that different packs are released. So this is what is in our trust, but it varies. So pack A and pack B, it contains different things, and that you go sequentially through those, and then once you go to pack C, you'll keep getting packs until you stop it, essentially. So the next thing I want to talk about was hypoglycemia. So that occurs when the blood glucose falls below 4. This is something you'll probably get bleeped about at some point. It's really important if you're doing an A to E to not forget glucose. It's really easy to do, and it is easy in the midst of getting called to someone unwell or unconscious to forget checking something really simple. So if anyone has any of those symptoms, or if you're just doing an A to E anyway, it is worth checking that, because it can happen in patients that aren't diabetic, and that can catch you out. In terms of management, it's easy to split into kind of hypoglycemia into mild, moderate, and severe. So they might be hypoglycemic, but they're still conscious, alert, and able to swallow. Or if it's a bit worse, they might be able to swallow but confused or aggressive or disorientated. If it's severe, they might be unconscious, aggressive, fitting, or not able to eat anything at all. So for mild, you just want to give them some fast-acting carbohydrates. If it's moderate, and they're capable, then just treat as mild. If not, then use some glucose gel, squeeze it into their cheeks, rubbing it into their cheeks, but make sure you're not putting your hands kind of near their teeth, can aid absorption. And if it's severe, you'll need IM glucagon or IV glucose, so they'll need access for that. Once you've given them some form of treatment, check the blood sugar again in 10 minutes. If the patient remains unconscious or is nil by mouth, you might need a dextrose infusion. But at that point, I'd be wanting to get a senior involved. And if I had an unconscious patient, I'd probably be getting help pretty soon. once you've treated the hypoglycemia, don't withhold the insulin or medication that they're on. Make sure that it's if they recover from the hypoglycemia, avoid rebound hyperglycemia. And if the IV insulin has been stopped, resume it, but it may need a review. And it's important to remember that variable rate insulin, which I'll come to talk on in a second, is not a treatment for hypoglycemia. If someone has had an overdose of their insulin or oral hypoglycemics, then hypoglycemia may be prolonged and require a dextrose infusion. And continue regular blood glucose monitoring for 24 to 48 hours. And long term, if they've had a hypoglycemic episode, they'll need a medical review of their insulin medication. In our trust, we have like yellow hypoglycemic episode labels, so it's quite useful when you come to like do the ward round. If they've had like 4 episodes of hypos over the last 5 days, they're quite obvious, and that can trigger you to review their medication. Another thing I definitely didn't really understand before I started working was variable rate insulin infusion, also known as a sliding scale. And this is commonly achieved to achieve normal glycemia in hospital patients. It's essentially an A4 sheet which you sign as a prescription, and it involves giving a constant insulin infusion in which at set periods the blood sugar is monitored, and then the insulin infusion dose is adjusted based off the blood sugar measurement. So if the blood sugar is high, the insulin is increased. If the blood sugar is going low, then the insulin is slowed down or stopped. In terms of when you use it, there's really useful guidelines about that, because it can be a little bit confusing about when to start it and when to not use it. It's essentially for type 1 diabetics not eating and drinking, or patients taking regular insulin and hypoglycemic and unable to drink and unable to amend their usual insulin regime, vomiting or severe illness. And it's not for DKA, HHS, ACS or hypoglycemia. When do you use variable rate versus fixed rate? So variable rate would be for the reasons set out there. Fixed rate insulin is used in the treatment of DKA, and I think, although I can't remember off the top of my head, HHS, but it's in the management of DKA where you'd used fixed rate insulin, although the fixed rate insulin also would be monitored carefully, if that makes sense. So variable rate insulin is if they're not eating and drinking, not in DKA. If a patient is in DKA, you'd want a fixed rate insulin, if that makes sense. But it can be quite confusing to get your head round. So if you're confused, it's definitely something that would be acceptable to speak to the med reg about overnight, because it's not always clear. And sometimes the nuances of managing someone's blood sugar when they're unwell as well can be challenging. So the other end of the spectrum would be hyperglycemia. So if I got bleeped about hyperglycemia, the key things I'd want to know would be what their blood sugar was, what the ketones were, and whether they were type 1 or type 2 diabetic. Important things to consider is, have they been given their insulin, or has it been missed? Is the patient taking steroid therapy, because that can increase your blood sugars? Is there any sign of infection? Again, that can increase blood sugars and put you at a higher risk of DKA. And is there any suspicion of acute coronary syndrome? Because patients with ACS are at a higher risk of having hyperglycemia. And for patients that do have hyperglycemia, there are poorer outcomes. So good glycemic control in the context of ACS is important. At our trust, and it might vary elsewhere, we have a protocol that we can prescribe, which has PRN Novo Rapid. And so if this is on their drug chart, then the nurses can give that if the patient's blood sugar goes up, although they normally give you a call just to let you know and say, are you happy for me to give it? And then, yeah, they do. But some nurses are quite happy and comfortable managing hyper and hypoglycemia, and some will give you a call just to let you know, depending on how high or low it is. The two kind of main conditions you want to be aware is DKA and HHS. So diabetic ketoacidosis or hyperosmolar hyperglycemic state. I've kind of put a very brief summary of the three definitions for both those conditions. So DKA is a high blood sugar, acidosis, and ketonemia, so ketones higher than 3, and HHS is a BM greater than 30, hypovolemia, and osmolality. I'm not going to go into the intricacies of treating both those conditions in this talk, just because they're quite detailed and there's not time. But for each condition, there is quite set out hospital guidelines on how you manage it, what you give, and how you monitor it. And it's just important to be aware that for both these instances, the patients will require quite significantly more intensive monitoring and of blood sugars, blood gases. So it's definitely something to make a senior aware of if it's happening overnight. Next, I just wanted to talk a little bit about cardiac arrest, as if you're on medical on calls, you often carry the crash bleep. So I've carried the crash bleep like throughout F1 and F2. If for any reason you're on the ward and someone tells you that they feel that a patient's heart stopped, I'd say the first thing to check is that they are for resuscitation. Even if they get a bit brief CPR, but the first thing you want to see is whether they've got a respect form. So in kind of nationally, it's called respect. We have something slightly different in Truro called a treatment escalation plan, but every hospital should have them. And if they're not for resuscitation, then you don't need to start CPR. However, you might want to see what they're for. So it might be that they're not for CPR, but they are suitable for, fluids, antibiotics. That doesn't mean that they won't benefit from a critical care outreach or a met call. So it's important being aware of what the respect or TEP form says. If you're at a bedside and you feel you need a bit more help, then pull the emergency buzzer. And if you feel like you need a bit more help in terms of a met call or a crash team, then put out the double twos, making sure to tell your location when you speak to switchboard. In terms of who's on the crash team, again, might vary slightly between different trusts. But normally there's a medical registrar who normally, but doesn't have to, anyone can lead if they've done ALS, and kind of may lead in the decision making. There should be an ICU trainee who helps with airway management. A senior anaesthetic trainee can come for advanced airway support. That's if required. They at our trust don't come immediately. They have to be bleeped. An IMT or F2 will do manual defibrillation and airway management. And then you as the F1 might do access, drug delivery, documentation, or CPR. There's often a couple of nurses who will do defibrillation, basic airway management, airway assistance, drug delivery, CPR, equipment preparation and documentation. In Cornwall, we get critical care outreach come as well, who do assistance with air management and are useful if we are thinking about moving the patient to somewhere else, like intensive care, and facilitating that transfer. And then during the day, you might have a resuscitation training officer as well, who can help with supervision, education, and a sort of supportive role. It is quite stressful and overwhelming when you go to your first couple of arrests. It's even if you've been to some as a medical student, I think going and having to actually do a role does take a bit of an adjusting to, and just having that, being able to actually do manual skills when you are a bit stressed and overwhelmed takes a bit of getting used to. They normally will ask you as an F1 to do access, CPR, or documentation. If you're struggling with access, that's absolutely fine. It is really difficult getting access in an arrest sometimes. But if you're struggling, just verbalise that and let people know, because then someone can help you or someone can take over and you can swap with the role that they're doing. Again, I think in your head, I'm sure you are all really familiar with arrests, but in the moment you can kind of forget the basics. So just remember that what we are treating is either a shockable or non-shockable rhythm. So if it's shockable, it would be VF or VT. And if it's non-shockable, it would be PEA or asystole. In terms of defibrillation, It varies depending on where you work about when you do your ALS. So I actually only did mine in F2. Some people do theirs in F1. If you've done ILS, which most people I think should have done, then feel free to just stick in AED mode. If you've done ALS, then stay in manual mode with the defibrillator. So with the defibrillators we have in Cornwall, when you turn it on, you can either press manual or it goes into AED. So if you don't feel comfortable making a decision about the rhythm, then just stay in AED until someone more senior gets there if you're the first person to arrive. Again, I'm sure you will know this, but looking at the reversible causes, so hypoxia, hypovolemia, hyper or hypokalemia, hypo or hypothermia, and then thrombosis, tension pneumothorax, tamponade, and toxins. This is why it's useful to get a gas, because it gives you a bit of an idea about all of these things. For shockable rhythms, after the third shock, you give 1 milligram adrenaline, 3 milligrams amiodarone, and then adrenaline every 3 to 5 minutes. And then after the fifth shock, it's 150 amiodarone. And for non-shockable, as soon as you've got access, you give 1 milligram of adrenaline, and then keep giving it every 3 to 5 minutes, and no amiodarone. Just a note on if you think that it's thrombosis is the cause of the cardiac arrest. So if you thrombolize a patient, you have then committed to 90 minutes of CPR. And these are a couple of things that might suggest a PE is the cause. So collapse or hypotension, unexplained hypoxia, engorged neck veins, history of recent PE, DVT, risk factors for PE, DVT, and initial rhythm of PEA. And persistently poor end tidal CO2 from outset despite good quality CPR. Can you just go back to the shockable drugs, please? I might go on at the end if that's okay. I can go over them. I'll carry on because we've still got a few slides to get to. So mechanical CPR devices are something to be aware of if you have thrombolized a patient, or they might come into ED sometimes. So they give mechanical chest compressions. There's two main makes or brands of mechanical CPR devices. So the one on the left is called an Autopulse, and then the one on the right is called a Lucas. The Autopulse has a flat backboard and then the kind of a soft fabric bit that goes over the patient, and the Lucas has kind of as you can see, a bit of an arch with the compression device that comes down. And they're often located at 2 places in the hospitals. So it might be that if you thrombolize a patient, that's required. If you get ROSC, then post-resus care is characterised by stepwise increase in requirement for invasive support and monitoring. So if it's happened on a ward, it'll often be that patient needs to be moved to coronary or intensive care. It sometimes happens that if it's happened, the patient might go via CT. I've seen that before, but you won't have to facilitate that at all. By that point, critical care and critical care outreach will be allowed to help to facilitate that. So lastly, I just wanted to go through some top tips, which I wish I'd been told, or maybe was told at the start of F1 and didn't listen to. So hopefully this will be helpful. I'm sure some people have told you, but there's lots of apps around, and some of them are really useful to just have on your phone. The Foundation Doctor Handbook's really good. It's just got lots of guidance for kind of common things you'll be asked to, both during the day and at night as well. MD Calc has things like the Wells score for DVT and PE, PERC score for PE. It's got good cognitive assessments as well. MUST score for nutrition. BMJ best practice is obviously really good for if you can't quite remember how a condition is managed or what investigations are required. Switch used to be called induction. It's got you can basically set it to the trust you're working in, and it's got a list of all the extension numbers you'll need, and bleep numbers as well. iResus, actually, if you're asking about the shockable drugs, you should have access to these slides. But iResus has all the Resus Council guidelines, so drug doses, algorithms in an app format, which is really useful. Geeky Medics has an app, but I also just use the online website as well. I thought you'd stop using Geeky Medics when graduated. You don't, it carries on, and it's great. It's really useful, particularly for some practical skills, which you can sometimes have a gap between doing. So if you get bleeped to do them out of hours, like there's no shame in looking at Geeky Medics to make sure you do it correctly rather than incorrectly. Talkspace is particularly useful if you've got a job in ED. I've only used it once on the medical wards actually, but it is if anyone has overdosed on anything, it just gives you the guidance on what to look out for, what needs to be monitored, what investigations you need to consider. Up to date, bit similar to BMJ best practice in that it's got guidance on just conditions, etiology, diagnosis, presentation, and things like that. BNF, hopefully pretty self-explanatory. Smart Doctor's really good. It has like common presentations and things you might get called about on call. And Microguide is obviously useful if you're prescribing any antibiotics. It's trust specific, so like you can update it and it has your specific trust guidelines on for local local antibiotic guidance. There's an Oxford handbook for the foundation programme, again quite useful. You won't necessarily carry it around with you on calls, but definitely useful to get. And there's lots of hospital resources as well. Again, this is something I really didn't make the most of or know that much about. Annoyingly, a lot of hospitals don't always set out their guidelines in an easy to find format. So maybe when you start, just have a little bit of time looking at what's there, what you can use, because there's probably lots that I definitely didn't make the most of. We annoyingly have like our guidelines, and then we also have an intranet with some other information resources on as well. So things might be stored in more than one place. And this is what one of my clinical tutors said to me when I was at uni, which I think is really pertinent for the world we live in now. We have so much information at our fingertips on our phones. Being a doctor used to be about being the library where you had to know everything and remember everything, and you didn't have the internet when you were on call. And now you can be the librarian. You can pick and choose. You know what's there. You can go and find it, but you have to know where it is. And finally, don't be afraid to ask for help. It's F1 is a massive learning curve. It's a big change from being a student. For the first time, you have to take responsibility, and nothing really prepares you for that. But there are people to help you. You know, you have seniors. You should be able to ask for support, and if you can't, that's not okay. It's not, you know, I probably asked so many stupid questions when I first started, and everyone does, and we know that everyone's been there, and they know that the first kind of job's going to be a lot for everyone. But you can do it because you've learned lots and you've spent a long time training to do it. This is another thing which I think I knew about before I started work, but one of the ACCS trainees also told us about it. There will be times where you go and see a patient and your heart rate is higher than the patient's, and you don't know what to do, or you're trying to do something, a physical skill, and you're struggling to, because you're stressed, you're actually struggling to do a manual task. Doing box breathing, of breathing in and out and holding for 4 seconds, physiologically can just slow down your heart rate. And I found times where I'm like struggling to do a cannula, or I'm at an arrest and I'm struggling to get access. And actually this has really helped me focus and then kind of get the skill done. And finally, or getting to the end, make sure you make the most of your days off. It's really nice going from being at medical school where you normally are looking forward to the next exam and you've normally always got something to do when you get home. In F1 and F2, for the first time, actually, when you walk out, you don't have to go home and revise or do more work. So make the most of that and enjoy your days off, enjoy your 0 days, and enjoy your annual leave and do fun things with them. This is a beach near where I live, which is really lovely, and I've spent lots of time on beaches in F1 and F2. So yeah, like make sure that you are getting that downtime as well. And sometimes you'll have a day off and you just want to sleep for all of it, and that's okay. Like, it's tiring starting work and getting used to working and getting used to being a doctor. So if you want to just stay in bed for a day and watch Netflix, that's all right. I've definitely done that, and sometimes that's what you need. So listen to your body, and if it's telling you need rest, then listen to it. And again, we've all been there, and this, I think, might explain why if someone snaps at you, they're snapping at you. I would say 99% of people in the NHS are nice and are just trying to do the best job that they can. But people will, everyone's quite hard worked and everyone's quite tired. So if you feel like you're being a bit grumpy or someone else is being a bit grumpy, it's probably because they're hungry, angry, late, or tired. And recognize that in yourself. And if you need to eat, go and eat some food, because you will be better, and you don't want to be tired and hungry and make a mistake. So if you can feed yourself and make it a bit better, then do that. And then finally, just a couple of things about looking after yourself. So make sure that you know how to accept and report. You should be told more about this when you start work. But this is so that you can, if you finish later than you should, that it's documented and you get paid for it. Every hospital should have a guardian of safe working who makes sure that hours are kind of in keeping with kind of what they should be. The BMA website is really good for guidance on breaks, raising concerns. Make sure that you have someone you can talk to. This might be your clinical supervisor, your educational supervisor, friends, colleagues, or someone you trust. And if your hospital has it, I'd recommend getting involved with the doctor's mess. They often put on social events. It's a really good way to meet people if you're moving somewhere new. When I started F1, I moved down. I didn't know anyone at all. And it's been great. Like, I've made really good friends. So like, get involved. Everyone's in the same boat and is keen to make friends. They're just the references for everything I talked about tonight. And that's me done. I think we've got just under 10 minutes for questions, if anyone has them. Just saw Ellen asked about shock or drugs. I think you'll be sent out the slides. Is the daytime on-call the same as the night? It depends on the hospital. So during the day, we don't really have an on-call because the wards are covered by doctors. At my trust, we have evening cover, which is the same amount as night cover. But during the day, the individual teams will manage the ward. It varies. The only time you'll be on call during the day is at the weekend. At my trust, you cover a specialty at a weekend, so you might cover endocrine or respiratory. But again, it varies. The cover varies quite a lot between different trusts about how they do it and how they divide the workforce. Any other questions at all? Perfect. If no one has any questions at all, then I think we'll stop there. Oh, let me see if I can go back to the chocolate jobs. Let me see. We'll see how quickly my internet can go back. There we go. Ellen, there's the shockable drugs, but also on the iResus app I mentioned, they should be on there. Or if you go on the Resus Council website, the guidelines are there as well. Would they put you on clerking at night? So not in F1, so not medical clerking. Medical clerking is only done by, you wouldn't do it in F2, so it must be IMT and above. You would do surgical, so you do surgical clerking as an F2, and as an F2 you'd work in ED overnight, so you do everything clerking. But it's different in different trusts about what people are put on what at different grades. So as an F1, probably not, because F1s don't do nights in ED. So I'd say an F1 probably wouldn't be put on clerking overnight. I'd be very surprised if they would. And if they were, it'd be heavily supervised. I hope that answers your question. But it depends on where you're going. Fab. Any more questions at all? In terms of IB, like you mentioned, if it's rising significantly and you're worried about malignant hypertension, then look for papilledema and maybe dipstick for proteinuria. Yeah, I think it would depend what the other symptoms were. I think if I was worried that there was something sinister going on, yeah, I'd do a full review and then go from there. I think actually it's quite difficult to get the equipment you need overnight, and getting stuff on the wards. I think I've actually never overnight, I've never had anything over 180. So it's not very common. And I think malignant hypertension and finding the cause of it is something that would be quite hard to find overnight. So I'd want to get someone senior there, because I don't know how much I would feel confident, diagnosing papilledema overnight. I think it's just the things that are important to consider. And it's actually like what would be feasible to be done overnight and what the cause of it is. Again, that might be because I've been working in a smaller DGH. But I think if it was over 180 and the patient was getting kind of the red flag symptoms, I'd want to know exactly what had been going on and get someone else to look at them as well. Like even now as an F2, I'm pretty happy to get someone else to look at things. I think sometimes 2 sets of eyes are better than 1. Sorry, I hope that kind of answers your question. So yes, I would look for papilledema, but it might be difficult to feasibly do. Cool. I'm glad it answered your question. No problem at all. I think you'll have access to the slides if you need them. Fab.
Thanks, Sophie.
No worries at all.
Okay, really useful even for me.
Oh, I feel like I learned stuff from doing this talk too. Good luck with all starting. You'll all be fine. It's very nerve-wracking, but everyone gets through it, and you'll all be grand. All right, good luck with starting.